Hi, my name is Dr. Jae Chun. I am a plastic surgeon practicing in Newport Beach, California. My practice is devoted entirely to breast implant removal. Recently, I participated in the annual meeting of the American Society of Plastic Surgeons. It was a panel devoted to En-Bloc total capsulectomy. I was asked to discuss definitions, indications, and complications associated with En-Bloc total capsulectomy. This video is a copy of that presentation. There are a couple things you have to remember as you watch this video. Number one, this video was created for practicing plastic surgeons. It assumes a certain amount of basic knowledge, and so some of the viewers might find some of the terms I use not familiar. Two, the original version of this talk was 30 minutes. But when the meeting announced the limit at 15 minutes, I had to cut a lot of the important details. And when the COVID infection forced the meeting to go virtual, the time limit was cut even further down to 10 minutes. As a result, a lot of what I wanted to discuss, unfortunately, had to be cut out. As a result, some of the viewers might wonder, why is he not talking about, for example, breast implant illness? Is that not important? Yes, it is important, but you have to remember I was given 10 minutes to talk about 3 things. There just simply was not enough time. As you'll see in the video, I am sprinting from the get-go trying to meet that 10-minute time deadline. I hope you understand that, and please enjoy. I would like to thank the Society and Dr. Carr for allowing me to participate in this panel. It really is an honor. I'll be discussing En-Bloc capsulectomy. The term En-Bloc means as a whole. It was a term used to describe the oncologic principle of removing a tumor mass in its entirety, completely surrounded by a continuous layer of healthy tissues to avoid tumor cell spillage. So the key words are whole, continuous layer, avoid spillage. When applied to capsulectomy, En-Bloc means removing the entire implant capsule complex as a whole, surrounded by a continuous layer of intact capsule to avoid spillage. Unfortunately, the term is often misused and misunderstood. This is an example of an En-Bloc where a completely ruptured silicone implant is removed without any spillage because it was surrounded by a continuous layer of intact capsule. Removing the entire capsule without tearing is difficult. Capsules are often adherent to the underlying rib cage and thin. In order to perform En-Bloc, some degree of tissue cooperation is necessary but not always present, such as thicker capsules and loose pericapsular tissue plane. The capsule this thin is difficult to remove En-Bloc. As a result, En-Bloc is not a guaranteeable or requestable procedure. We also have another term, total capsulectomy, which means removing the entire capsule. En-Bloc is often misused to describe total capsulectomy. This is an example of total capsulectomy and not an En-Bloc because there are holes. Spillage can occur. The fact that the entire capsule came out does not make this an En-Bloc. The fact that the capsule is still surrounding the implant does not make this an En-Bloc because holes will allow spillage. So as a result, total capsulectomy is the term that we should be using as it is guaranteeable and requestable procedure. So I believe the panel's question is really more total capsulectomy or not. In other words, do we need to take the whole capsule out? Thick calcified capsules, obviously that all needs to come out. 2, ruptured silicone implants. Leaving capsule behind will leave residual free silicone. In cases of ALCL, the entire capsule must come out for diagnostic and therapeutic purposes. For breast implant illness and patient request, many publications support this indication. This article appeared in the supplemental issue of PRS in 2019, authored by Dr. Diva. Our own doctors Patricia McGuire and William Adams were co-authors. It stated, a substantial number will be improved by surgical implant removal and capsulectomy. This article appeared recently in the Annals of Plastic Surgery, authored by Dr. Lu-Jing Fang, where total capsulectomy demonstrated significant and sustained improvements in 11 common symptom domains associated with breast implant illness. FDA in 2019 stated, the current evidence supports that some women experience systemic symptoms that may resolve when their breast implants are removed. In the July 2019 issue of PRS, Dr. Rod Rohrich stated, if a patient chooses to have implants removed, she should consider having the entire capsule removed. He does go on to say, unless the posterior capsule is adherent to the chest wall, which may increase the risk of pneumothorax. So what are the risks of total capsulectomy? I was not able to find any large reviews describing complications. So I took the liberty of reviewing my own 2019 cases. So these are from January 1st to December 31st of 2019. There were 460 consecutive cases of implant removal and capsulectomy. All of them were total capsulectomy. 1/3 of them were true En-Bloc total capsulectomy. Photos of every one of these cases are available for viewing on my Instagram and Facebook. The age of the implants removed ranged from less than 1 year to 40 years, with median of 12 years. 404 patients, representing 88% of the patients, had breast implant illness symptoms. Of this group, 176 had saline implants and 228 had silicone implants, dispelling that notion that only silicone implants cause breast implant illness. 147 patients, representing 32% of the patients, had successful En-Bloc. Those with subglandular implants had higher chance of En-Bloc at 76% versus a 24% for submuscular implants. En-Bloc is critical when there's an underlying ruptured implant. There were 50 such patients in this review. Age of the ruptured implants ranged from 5 to 37 years with median of 17 years. 41 patients, representing 82%, had successful En-Bloc of their ruptured silicone implants. All 100% of the patients with subglandular ruptured silicone implants had En-Bloc versus 73% of those with submuscular ruptured silicone implants. The incidence of successful En-Bloc was higher in those with ruptured silicone implants than the overall group. Although there are many reasons, I believe the main reason is that the capsules tend to be thicker when there's an underlying implant rupture, possibly due to irritation from free silicone gel inside, but also these are older implants, as evidenced by the median age being 17 years versus 12 years for the overall group. Older implants and capsules often have more calcifications and the capsule's thicker. What is the incidence of complications, or is total capsulectomy safe? There were 40 complications altogether, representing 8.7% complication rate. All of them were minor except for one case of reoperation due to cosmetic distortion. There were no cases of nipple areolar complex necrosis or pneumothorax. I divided them into two different procedures I performed. 28% of the patients underwent removal only through the inframammary fold approach. Since it is a shorter procedure with simpler incision, predictably the complication rate was lower at 3%. 72% of the patients, representing 333 patients, underwent simultaneous wise pattern mastopexy. My preferred approach, which can be done in about 80% of the cases, the nipple is on the superior pedicle. Infraareolar deep incision is made with vertical extensions along medial and lateral pillars, creating an inferiorly based dermal glandular flap for auto-augmentation. This approach also gives you central access and wide exposure, facilitating the dissection. In this simultaneous mastopexy group, there were 36 complications, representing 10.8% complication rate. All of them were minor except for one case of inframammary fold distortion after a muscle repair. This is a list of minor complications that I encountered. Of note are the non-surgically managed small hematomas. There were 6 in this group, 2 in the removal-only group. Typically, my hematoma requiring surgical evacuation runs about 1.5%. In that sense, 2019 was very unusual in that none of them required a reoperation. There were no cases of nipple areolar complex necrosis among 333 patients that underwent a simultaneous mastopexy, so that can be done safely. But surgical incisions must be adjusted for vascular disruptions caused by previous surgeries. There were no cases of pneumothorax. Pneumothorax is not unique to capsulectomy. It occurs with breast augmentation and breast reconstruction using expanders, and yet we don't consider those procedures too risky to perform. In this article written by Dr. Stevenson in 2005 PRS, a survey of California Plastic Surgery Society members showed 1 in 3 had experienced a pneumothorax after breast augmentation. 1 in 10 had 2 or more such complications. This article by Dr. Cordero in the Annals of Plastic Surgery describes 0.04% incidence of pneumothorax following a breast reconstruction with expanders. He also describes 0.55% incidence of pneumothorax in the national database. You must stay above the muscle to avoid pneumothorax, but you also have to stay above the fascia, as right underneath the fascia runs these large branches of the intercostal vessels. When these are cut, they bleed profusely, and the cut ends retract into the muscle fibers, making hemostasis extremely difficult. I believe that repeated cauterization, trying to control this difficult bleeding, that causes pneumothorax. In conclusion, total capsulectomy, including En-Bloc, can be safely performed by qualified plastic surgeons with comparable risks to other plastic surgery breast procedures. Thank you.